going to do a quick bio, and then we'll, yeah, okay. Are we ready to go? Good morning, testing, can everybody hear me? Yeah, okay, we're ready to go. Wait, I'll put this somewhere. Okay, good morning, everybody. Thank you for being here. Excited to welcome you. My name is Julie Kornfeld. I'm the Vice Dean for Education at the Mailman School of Public Health. I know in our audience we have alum and current students and many important supporters. And we have a member of our Board of Overseers here, Dr. Barbeau, and an alum, Dr. Castrucci, here. So I'm very excited to welcome you. I'm going to give you a little bit of a background, and this is going to be an informal dialogue. I'm going to ask each of them a couple key questions. You'll have a chance to ask some questions. It's just a chance for us to get to know one another and talk about some important issues in public health. So thank you for being here, and thank you for joining us. I just want to say this is a first of a series we're calling Leaders and Luminaires. So you're our first Leaders and Luminaires. And it's really an opportunity to bring together key leaders, both in public health, who have connections to our school, and bring a level of conversation to our community. So thank you for kicking off this exciting series for us. We're happy to have you. We have several members of our alumni board. I don't know if I see the president of our board here at the moment, but it's running late. Okay, so I won't have him stand up. And I want to thank you both for being here and give a quick background, although I think most of you know Dr. Barbeau is the Commissioner of Health here for New York City. She took that position in December 2018. She has more than 25 years of experience in public health and really has dedicated her career to achieving health equity. Really excited to have you join us today. Dr. Castrucci is the President and Chief Executive Officer of the Du Beaumont Foundation, and been there over 7 years, and has really helped, most recently as the CEO, really helped build the foundation to be a leading voice in health philanthropy and public health practice and advocacy. So thank you for joining us. So in preparation for this session, we all had some opportunities to talk, and one of the things that we talked about was the fact that public health has become incredibly political. I think something we would all agree. And in the school, we don't always discuss public health in those terms, although I think we would all agree that politics shapes the social, the economic, and the environmental conditions that shape our health. So I think what I would like, and at the Mailman School, at least for me and the dean and many of us in the faculty, we are constantly examining, what do we do better? How do we next prepare the future generation of public health leaders? And so we've got two pressing issues among many, I know, vaping and measles, and maybe in your introductory remarks from your different perspectives, you could speak a bit about how these current crises are challenging you as leaders, and how that current situation informs your work and your leadership, and the skills that you need from your workforce. I didn't flip a coin to see who gets to go first.
Yeah,
You're gonna let Dr.
I'll defer.
Oh,
I'll defer
okay.
to the guest in our city.
Oh, okay. Well, there you go, Doctor. You're on.
So thanks to everybody for being here. This is really exciting. As someone who is an alum who was at the 168th Street campus not so long ago, this is just really exciting, and I'm humbled to be here. Yeah, it's like really political. It kind of sucks right now. And we have to be, I'm not government, so I can, this is what the fun part's gonna be, okay? I don't have a leash, because I worked for 10 years in governmental public health, and then I shed my leash, and so I can speak truth. And the beauty of philanthropy is there's a second part to that no one ever tells you. Like, you can speak truth to power, and there may be some consequences, right? I can speak truth to power without those, because we have our own money, we're privately funded, and my board knew what they were getting when they bought me. So, we need to do more and more of is really think about how we build bridges and how we speak truth. Because ultimately, there are some human values that are being violated. And if we're not speaking up on those issues, then we are not serving our constituencies, and we're not serving the reason that we got into this work. And I'm totally happy to write blogs and to speak on the immigration crisis, and that's just wrong. Like, and if you think it's right, like, come talk to me. Like, I'm still like someone come and tell me. That's the beautiful thing about health. And if we do it right, then we can bring everyone together. Because if you think about, we talk a lot, we talk about housing crises, we talk about crises. We talk about social determinants of health. No one wants to hear about social determinants of health except us. So what if we started talking about foundations for a strong community, foundations for a strong worship, foundations for a strong economy? All of that gets back to our stuff, right? Because if you have a house, no matter how good the wallpaper is and the curtains are, if the foundation of that house is ill, then that whole house will fail. And ultimately, everything that we want to do, whether it's go to church or whether it's have a great business or whether it's enjoy our lives, all of that is predicated on having a strong foundation for our community. And that's about housing and economy and justice. And we need to have that conversation, right? Because we seem to have a policy perspective in this country right now that if I only clean half the fish tank, all the fish will just be fine, right? But if you clean half a fish tank, eventually all the fish are gonna die. And I think my question right now is how soon before we actually hit that point, right? And how do we start to think more about, we have this over individualized lens. I would argue that toxic individuality is slowly killing our culture. We have since the 80s have kind of focused on medicalization and criminalization, and we are slowly but surely destroying civilization. Because we took people who were poor and people of color and made them either patient or prisoner, and in doing so, we obfuscated our responsibility as a community because it was your fault. You made that decision. I didn't, and I can't help you. If you can't make good decisions, I can't help you. Now, we're not going to talk about the fact that you've seen tobacco advertising since you grew up, that everyone in your family smoked. We're still going to make that about your decision, and this is our problem right now. We've lost the us when we've kind of shifted to the I. And that's why even now when we talk about how many hospital systems are trying to deal with social determinants, they're actually not dealing with social determinants, they're dealing with individual social needs. Because it's what they can control and it's doing it on an individual basis. Because to do the community level work, it's gonna hurt a little bit. Like developers, listen, if there's a developer here, I hope you make money. Totally down with you. But like if you're gonna make this much money, maybe you should only make that much money. And then maybe give this back to people who've been displaced by you, right? We need to start taking care of us. In Seattle, a really good family who's working and mom works, dad works, kids go to school, everything's great. They go to renew their lease and the lease is jacked up by a factor of 7 because some hipster is now working at Amazon and they really like the food market down the street and they're more than happy to walk to work. So now that apartment's $7,000, which the hipster's willing to pay. But this family can't pay that. Now they're living an extended stay. Then slowly but surely, mom starts drinking because this is like not something she was really prepared for. It upset her whole life. Kids start going into criminal behavior and making some bad choices. Dad loses his job and now they're homeless. Whose fault was that? That was our fault. That was our fault for not putting a simple protection in to make sure that you can actually have a life in a city with good controls over rent, and we're not protecting our people from predatory capitalism anymore. And that's a huge problem. And if we don't stop it, I don't know how much longer the fish are going to keep swimming.
Okay.
All right.
Your turn.
All right.
You can maybe focus a little more on the measles and the vapings because I know they've consumed your focus for a while here, among other things.
Yes, indeed. So good morning, everybody. It's a pleasure to be here with you today and to share the stage with Brian. We have collaborated over the years, and I think that this is actually the first time that we're on the same stage together. So it's kind of like point counterpoint, but in a good way. So when we talk about the intersection of politics and public health, I think it's important to sort of go back to the beginnings of public health, if you will, to say that there's always been the intersection of politics and public health. And public health has always been political, but it feels like the current days that we're living in, it is that much more acute and the stakes are that much higher. Recently, I've been talking a lot about the measles crisis, and I'm not going to get into the details of measles here, but really use it as an example of how the foundations of public health are really being put to the test. And what I generally say is that the measles crisis has given us an opportunity to provide yet another example of how, on a roughly daily basis, public health always has to balance civil liberties with civic accountability, and that inherently that then creates political tensions, because you have individuals saying, I don't want to do that, why are you forcing me to get immunized? And then on the other side you have communities where if we don't have a certain level of herd immunity, we have individuals who are unnecessarily put at risk, and what about their rights? And so that's, to me, is the crux of why it's important to talk about politics and public health, because whether it's measles or whether it's vaping or any other issue that we tackle that affects the lives of everyday New Yorkers, Americans, those are issues that we need to take into account. The other thing I will say that seems to have made, at least in my lifetime, this period that much more political when we talk about public health. And when I talk about political, I don't necessarily mean sort of red state versus blue state. I think this is just sort of political without any sort of nod to a political party, one political party or the other. Because, if we take an example of what Brian just raised in terms of immigration, and we narrow it down to the public charge issue, this is not the first time that this country has talked about public charge. Under Bill Clinton was the first time when we talked about public charge and limiting the access that immigrants have to things like health care, things like other food benefits. And so this is not about red state, blue state, Republicans, Democrats. This is about how it is that we are taking fundamental components of our democracy for granted. And it's an opportunity for us collectively to exercise our political voice, our collective voice, to really, A, realize what's important to us, and B, galvanize communities to fight for that. And so I guess the last thing that I'll say is what's made it that much more challenging, in my opinion, which is a continuation of what Brian sort of alluded to in the social determinants, and I couldn't agree with you more that nobody outside of public health even knows what social determinants mean, but when you talk about the way that you framed it, it really does resonate. But what I would add to that is, when we are now in a situation where corporations are people and have the rights of people, it makes the opportunity to make structural changes that much more challenging. And that's why this current crisis that we're in with regards to vaping is so critical for us, because we can't lose sight of the fact that we are living through a health crisis within a larger alarming epidemic, and that we can't let big tobacco hijack the framing of this conversation and get away with enlisting and recruiting yet another generation of young people on a lifetime of nicotine addiction. And so all of that sort of wrapped together has provided me a lot of substrate to practice my diplomatic skills, both domestically and internationally. And so we can talk about that through the conversation.
Well, I think those are 2 points I wanted to follow up with both of you on. One is kind of in this complex conversation, internationally and domestically, as leaders, what are the skills that you often draw upon to be able to kind of frame conversations in ways that translate into meaningful action for your constituents, for our communities of public health students, leaders, alumni. And then the second thing I'll come back to, which is you've both alluded to the need to collaborate across sectors, public, private, community-based, the media, and I'd like to talk a little more about that. But maybe first a little bit about, you already started with your diplomacy, but a little more about what is it that you rely upon in these times as a leader and you expect from your workforce, I think.
Wow, that's a great question. So there's a couple of layers here. I think the most important skill set that we in public health use on a daily basis and that I'm looking for in the workforce is individuals who are critical thinkers and individuals who know how to communicate and communicate in more than 140 characters, right? So, right, our president communicates in 140 characters very effectively, but we want to have critical thinkers first and foremost. And the importance of that is because we're in a situation where it doesn't serve us to continue the same old, same old. And having critical thinkers allows us to incorporate changes, trends that are happening in order to be more responsive to the communities that we serve here in New York City, but then also how that translates across the country. And we're only able to do that if we're critical thinkers and we're able to communicate in ways, both verbally and in writing, that have people understand the facts, right? One of the things that's so important in public health is not ceding our role, our central role in promoting the importance of data accuracy, and along with that, ensuring that our workforce is as skilled and as knowledgeable to know when to apply a t-test and when to apply an equity lens, right? Because we need to ensure that, as Brian alluded to earlier, that as we put programs together, we do it for all members of our communities, and that it's not just enough to lower the infant mortality rate for the city as a whole, but that when you break that out into the threads, you do so in a way that eliminates racial inequities. And so in communicating what we talk about with the public and with leaders in other countries, I think one of the things that's been really important for me is to start with equity, start with empathy, start with compassion, right? Because for the example of measles, I think it's important not to lose the people that we're trying to message by demonizing them, by judging them as being ill-informed, terrible parents, you name it. Like, that's the worst thing that I could have done, that we could have done. And so leading with every parent wants to do best by their kids. And then pivoting to anchoring what the data actually says and engaging individuals in a conversation. And I think part of what has sort of demonstrated to me how successful we've been in that is the fact I never thought in a million years we would have everyday New Yorkers, we would have the media talking about herd immunity. I mean, seriously, I'm sure that I remember back in the day when I was in medical school, I'm sure we had, questions on our exams about explain herd immunity, and probably half the people in it didn't get the right answer because there was no urgency to understand why it was important. But now, I bet that we've got high schoolers that can explain the concept of herd immunity. And so that actually works to our benefit. I think what I'll end with is to say, another thing that I've learned, and I think that's important for our workforce to be cognizant of, is that there should never be a crisis that goes untapped for valuable teaching moments, right? So the measles crisis gave us an opportunity to engage the public on a conversation about why vaccinations are important, and gave us an opportunity to remind various sectors of what the real science is and what the values are. Additionally, in this vaping crisis as well, it's giving us an opportunity to link the conversation between what's happening currently in terms of young people being recruited to a nicotine addiction through bubblegum, cotton candy flavors, to what happened over 50 years ago when Big Tobacco used the same tactic to recruit Black and brown communities to a lifetime of nicotine addiction. And so these are teaching moments that help us bridge between seemingly unrelated events, but that in the big picture make a huge difference for ensuring that we protect and promote the health of all New Yorkers on an everyday basis.
I mean, critical thinking, of course. Where are the students at? My grades, okay. Message. So I finished my doctorate a year ago, so I can still like
Relate
do
to
the
the pain.
student thing. You know? I think if you were in a master's program, if you're in a doctoral program, you know, you are so fortunate to be in New York City. And while this may go against academic dean's messaging, the grades
right
aren't
ahead.
grades aren't so important, right? Like, get experience. Like, I hire people. You hire people, but you hire people through a very odd and labyrinth system. Like, I literally hire people and just say, "You want to work for us?" But it's got to be like, what are you bringing to the table besides academics? Because that's not what, you know, the knowledge base is great, but you can't be just knowledge based. You need to be able to use these skills and being able to tell stories, being able to communicate. I think that's, I mean, we continue to fail when we go to a superintendent of schools and start rattling off public health data that he or she doesn't care about. They care about test scores and graduation rates and dropouts. And so how are we messaging to them? We're actually going to launch in early 2020 a toolkit called Phrases, Public Health Reaching Across Sectors. As someone classically trained in public health, I recognize that every program we do has to have an acronym. So Phrases was our acronym. We spent a lot of time on that. I think there was a course I took at Columbia, like how to make acronyms out of public health programs. This is a toolkit where we actually worked with other sectors to get their understanding of public health. And here's the thing. We might think that health is about a state of well-being, right? Free of disease and, you know, wrought with opportunity where everyone can live their best lives. That's not what anybody else thinks it is, right? Everybody else thinks it's about individual health and medicine, right? So we need to, as professionals, we need to be able to understand what our value set is and understand that not everyone else holds that value set. And we still have to work with them. Mm-hmm. Like, you may work with a large employer and maybe equity isn't their thing. Maybe they don't even think about it. All they're cared about is sales. As long as their sales are up, they're fine. So are we not going to talk to them? We have a policy program called City Health. Cityhealth.org, it's 9 policies across the 40 largest cities in the US. We went to Kansas City and worked with them on improving their policies. And the Chamber of Commerce said, we're not doing paid sick leave. It is a non-starter here. Now, the choice for us was then we go, oh, well, we're not going to work. If you can't do paid sick leave, then we're going to walk away from this. But we said, okay, that's fine. Take it off the table. What else can you do? And they're really working hard to get their city to a gold medal, passing policies, supporting early pre-K, T20, Tobacco 21, and other things. But we need to be better at checking our values and not being on our soapbox all the time. Just leave the soapbox at home, because I'd rather be effective than principled, right? I think I can get to principled over time, but I would, at the end of the day, when my career's over, I want to say what I changed, and hopefully that aligns with what I thought, but I don't want to have to say, like, I thought these really great things, but nothing changed, right? And on the measles thing, I've been thinking about this a lot, right? And so we have, like, you know, the diplomat and the bomb tosser, not legends and luminaries. So,
I didn't see that in your
You see
resume,
that?
bomb tosser.
it's the disruptor provocateur part.
Okay.
So I need some of you to come with me after this talk, because we're going to go up to the roof and we're going to start chucking stuff off, okay? Because I'm not sure of this gravity thing. I'm not sure if that's a real thing, okay? And then I'm going to hold a press conference. I'm going to talk about gravity and it doesn't exist anymore. And maybe we can just, like, you know, maybe the police will say, well, you can't throw stuff off the roof. I go, I didn't know if gravity was real. Right? I kind of get a little disturbed that we're having an anti-vax conversation because they're just wrong. Like, to me, they are tantamount to the person standing in the quad with the big sign, "World will end tomorrow." But we're somehow engaging them in a conversation when they're just wrong. Like, 2 + 2 is not milk, right? And if you said, what's 2 + 2? Milk. You would say, that's just not right. Let me educate you on why it's not right, but let's start with the basis of it is not right. And so the diplomacy of having to work with constituencies is totally there. But those of us who don't have that, I mean, guys, it's just, we need to be clear about the science is proven. This is not a debatable issue anymore. And we need to look really, really hard at how that movement was allowed to gain traction. Like, I would say if you have students who are anti-vaxxers, suspend them. Just suspend them now. They're just wrong. Right?
I'll bring that back to you.
Yeah, bring back to the dean. It's just, but there are truths, and our science gave us truth. Like, if you had a student who wrote a paper on the fact that we actually don't have hearts and lungs, we have a clock, and it ticks and if we don't maintain it, the cuckoo will pop out of our chest. You would look at that person and go, okay, that's a little off, and you are wrong. We know there's a heart. When Kyrie Irving, the basketball player for the Celtics, who's now with the Nets, when he said the world was flat, that's just wrong. The world's not flat. We're not going to have a debate about the flatness of the world, right? And so I just think we have to adhere to some of the truths that we have and not debate the truths.
Okay. So I hear a couple of different things here that I think are
It's all on the spectrum.
right. It's all on the spectrum, but you're saying in many ways similar things in the sense that we have to change our messaging to ensure that we're keeping pace. Right? These are old conversations. Vaccine, tobacco. We thought we were ahead of those conversations, and we were moving on to other things like climate and things that were newer. But in fact, we're not, and we're having many of the same conversations. And I think the lens by which we have those conversations and by which we engage communities are really important. So I'll ask another question, and then I'm going to open it up for the students in the audience and the alums to ask questions. But we have an election coming up. We've learned that elections actually are important in public health, I think. I think many of us in the public health community, whether we're in the workforce or in the community, in the academic community, we want to advocate, we want to disrupt, to ensure that the right things are happening that will help ensure that all people have access to health. But I think there's challenges in how we do that. And so I think I'd like to ask you a bit, I think continuing on this theme of, we can't point and accuse people of, although we need to bring the facts into the conversation, but we want students ask me a lot, and we all want to have conversations with people who think differently than us so that we can engage and more broadly on some of the topics. And so I'd love your insight in terms of, it's going to get rough in the next, I think, couple months in terms of the dialogue and the conversation, and how do we manage that effectively? I'll let you go first. How's that?
All right.
Since you do this every day, I think.
Let me sort of take a stab at that in a sort of more public health data way.
Yeah.
One of the things that we as a department did a number of years ago, and it speaks to the way in which we are adapting public health and the way in which we approach public health based on what we are seeing in our current changing political world, and the way in which we leverage what we do best to help not only continue to improve the health of New Yorkers, but provide data for others to then take on for advocacy. So with the inauguration of this administration and the way in which rhetoric took a sharp turn in the country, and the way in which programs that we thought in public health were sort of a given were being eroded. We then took what we do typically in public health, which is, collect data. We are known for putting together monitoring and surveillance systems, right? That's how we have gotten to great gains in HIV and STDs, et cetera. We put that framework to work in terms of creating a monitoring and surveillance system for the way in which the rhetoric that's been happening in our country is affecting key indicators. And so paying attention to what's being discussed and then understanding how to translate that into what we do and then providing data so that it can be used for advocacy. So based on the rhetoric, we started collecting data on access to care, right? Talking about undoing the ACA. Based on the rhetoric, we started collecting data on things related to reproductive health, looking at infant mortality rates, looking at birth weights, looking at other indicators of access to reproductive health. We looked at ways in which we as a city could monitor what was happening with regards to environmental health and because of the assaults that were taking place for agencies such as the EPA. And then similarly, looking at the ways in which we could provide a monitoring and surveillance system for issues related to food insecurity, given what was being discussed in terms of the Farm Bill, being in terms of SNAP, et cetera. And sort of putting all that rhetoric together and creating a framework to say, how does this then potentially translate into the everyday lives of New Yorkers? And so we now, over the last 2 years, have a fairly robust, what I would call monitoring and surveillance for the impact of federal policies on the health of New Yorkers. And one of the things that came out of that monitoring and surveillance system that was published in collaboration with folks, Nancy Krieger from the Chan School of Harvard Public School of Health, Public Health, was that when we looked at the birth weights for New York infants born before the naming of the candidate for president and after his inauguration, we saw a distinct difference in the birth weights of infants born to women who noted on birth certificates that they were from Central American countries. And so this was, and everything else being equal, an indication that the rhetoric against immigrants was having real life biological consequences in the health of New Yorkers. And so that got a lot of press. We've looked at other measures, and the reality is that we have yet to see inflection points, right? And so we've been sort of scratching our heads to say, is that good or is that bad? And the reality is that for better or for worse, we live in a bubble here in New York City, right? That's one way of putting it. The other way of putting it is to say that we are fortunate enough to live in a city that has progressive values, that we live those values, that we put policies and programs in place that lead with the values of compassion and inclusion, and that we take care of one another. And that irrespective of whether you are an immigrant or not, whether you're insured or not, we try to create opportunities for all of us to benefit in a way that we create a more just and equitable city. And so I think the value of having that kind of monitoring and surveillance system is not only for us, but then to export it to other big cities across the country who may be sort of oases within larger political contexts where they may not be able to employ the same kind of protections that we enjoy here in the city.
Really interesting. So really a response to a public health response, which means you're collecting data so that you have the data to respond to and in timely fashion in ways that are meaningful to the city and to the media that covers the city, I would imagine.
Exactly. And so the way that I would sort of crystallize it and the advice that I give to young folks that are asking, how can we be involved? The way I narrowed down to 3 things, very simple. Do what you do best, right? So in public health, the things that we do best, a number of areas, but collect data. No one can claim the same level of accuracy and pristineness, if you will, of data, right? So we collect data. The second one is focus on the intersectional aspect of what we do, right? So that's why I talked earlier, and Brian alluded to the fact, public health and politics, health and housing, those types of things. And then also the importance of working across color lines, racial lines, right? Because it's not just about increasing the life expectancy of New Yorkers as a whole, it's ensuring that whether you're Black, white, Latino, whatever, everybody's increasing. And then the third thing is to focus on the ground game, right? I have a lot of young people that come to me and say, you know, this, that, and the other federal policy. And I'm like, that's great, but how does that play out on the ground in your community? How does that play out in Bed-Stuy as compared to the Upper East Side? And the importance of, you know, setting the foundation in your own community and then building from that. Certainly there's the argument that, you know, we're now so sort of global and connected by social media, and yeah, that's true. But in the end, in my opinion, it boils down to the relationships. And no matter how many, you know, friends and likes you have on whatever the social media platform is that you have, at the end of the day, that doesn't count the same way as personal interaction and the relationships that we build, and how that then helps to strengthen the social fabric of our city to be as inclusive as we are, and to continue building on that.
Thank you. You want to shake it up?
Agree, and I could show you data in a city about all the police abuse. I could show you charts, and I could show you tables. And that's good backup, and we need that information. What's going to move the community is the mom who's talking about her son who was beaten, right? We need the stories, okay? We are outmatched, we are outpowered, we are outfunded, right? So the only thing we have is our authenticness of the community and mobilizing that community to help themselves, to help move the needle on some metrics. And if I don't think we can continue to believe that people will see the data and become transformed and go, oh, I didn't know about that. Like, do we not, like, you know, people show me disparities data. And I don't know, I kind of knew that, right? That the data will confirm it. But, you know, stories stick. You can make people do almost anything with a good emotional story. Emotions move people to do things. Emotions move people to march. Emotions move people to vote. Emotions move people to do almost anything. It's, in a perfect world, underpinned by really good data so that we're not, you know, falsely moving organizations or people or community. But the data alone are not going to do the job for us. And for us, in this kind of coming election, and you went a whole talk and never said the T word. Like, I thought that was really cool. Like we don't know who's there and what he's doing. But I'm as annoyed with the Dems as well, because I sit listening to debates where health is never discussed. Health is never discussed. Health care is discussed. We are having a debate as if we're in a sinking ship, and the conversation the Dems are having is the size of their buckets and how much it costs just to bail the boat. But no one's really talking about the fact that, you know, affordable housing has gone down every year since, you know, the 1980s, right? No one's talking about the true drivers of health. Marianne Williams actually touched on it, but she also doesn't believe that depression's a thing and that vaccines are Orwellian. So I was sitting with friends watching a debate and like, I can't tweet that now. But how do we get, you know, again, ACA, I'm a huge proponent of ACA, but all that is about paying for sick people. It's not about getting people healthy, right? So we're willing to kind of like not invest in housing, but we're willing to just kind of wait till housing makes you sick, and then we'll pay to make you not sick, right? And, you know, the whole world changed when chronic disease surpassed acute disease is what killed us, okay? If eating cornflakes gave kids gonorrhea, what would happen to the cornflakes? Like, honestly, what would happen to them? They'd be recalled.
Right.
About how quickly?
Fast,
In like 30 seconds.
fast.
Yet we're having debates about soda and McDonald's and all these things in a very different way. See, because nobody benefits from kids getting gonorrhea from Kellogg's. But there are, and this is the reality that we live in now, there are any number of multinational corporations whose profits are predicated on us staying fat, addicted, and afraid. Right? And if you look at like how many more dead kids do we need before we do something on gun violence? I'm just asking. Like, give me the number so I don't have to bother you. Okay, so then when we hit the number, I will come back and we can talk about this. So, I mean, I think we need to be more thoughtful. APHA has done some work on how do we speak and do advocacy and, work at your local level, work at, have a candidate forum around health. And every time they talk about healthcare, buzz them, right? So that we can start to teach them the difference between an individual in a clinic and creating a community where everyone has a chance to achieve their optimal life. Because given the context we're in now, a city council person can have as much impact on your health as a clinician, if not more, right? Solutions for health are not coming from a laboratory, they're going to come from a legislature. And so we need to figure out how we're engaging. There was a really great article by Jake Williams in the Stanford Social Index thing. Jake runs Healthier Colorado, and his point was we need a C4 for health, right? Because all of the nonprofits that we have in health, we're all kind of hamstrung by the political advocacy we can and can't do. Private foundations, we can't lobby. Our money can't go to that, right? You can't lobby, right? So, I mean, there's all of us used to, I worked in governmental public health for 10 years. And there were things I would say over, a scotch, and there's things I said during the day. Now I get to have scotch all the time and say whatever I want. But this is the real fight for the soul. I mean, we're having a fight for the soul of the country right now, right? And it's about the question of, do we continue to want to just let a few people succeed, or do we want to go back to a system where everyone was able to profit and have some sort of forward movement? If you want a really good social determinants of health song, you have to listen to Allentown by Billy Joel, right? Like really, like go home. And for the students, Billy Joel's a singer.
A good singer.
I did a whole thing with one of my new staff about what is it like at DeBeaumont. I said it's like the A Team. Like remember the show, the A Team, and I'm like Hannibal and you're BA, and da-da-da. And she at the end she looks at me, she goes, I don't know what the A Team is, and I cried. And I've got my hip replaced.
Billy Joel song.
We could, hopefully, yeah. But Allentown talks about, there was a time when, people were working in factories and they were making good livings and they could have vacations and they could have homes, and those factories shut down. And we didn't do anything. We were like, oh, well. Like, do you know the best cup of coffee I've ever had is in the Austin airport. And it's made by a robot. Honestly, it's made by a robot. It's called Brigio. And it's perfect because it's perfect every time. And I look at that and I just wonder, like, well, where's this going, right? Like, how soon before all the baristas are out of work and we're not going to do anything for them? Or how, what is this coming revolution of AI and robots and computers, and where are we going to put people? Where are people going to have jobs still? Are we going to train them? Or are we going to continue to have the coasts kind of forget that there is a middle of this country, right? Because I hope this 2016 election is a wake-up call to everybody in this room, right? That not everyone thinks the way that we think. Not everyone, got to go to Columbia. Not everyone has resources. And if we don't recognize that there's a middle of this country that's being left behind and that their health is suffering, then we're not going to move forward in 2020, and we actually could risk losing again, right? I'm neither Republican nor Democrat. I am a healthocrat. Right? And I want to see really good communities built so that we can have a strong and thriving economy. Right? What made America great in the first place was our ability to be entrepreneurial and innovative. And it's so hard for us to do that now because half of our population has a chronic disease and they're locked in their jobs. So healthcare is important, but making sure that we have healthy communities, healthy streets. Look at our city health policies. Paid sick leave. How is it that we're in 2019 America and don't have paid sick leave? City of San Antonio just required every single employer, from 1 employee to 1,000, and more to have paid sick leave, right? That makes a movement forward. And we did that working with the brilliant health commissioner who is in San Antonio, Colleen Bridger. But these are things we have to think about. And I love our programs, and I love Nurse Family Partnership and all the home visiting stuff, and I did that for a long time. But those are just Band-Aids, and I can't do Band-Aids anymore, right? Because if you don't stitch up the wound, sooner or later you bleed out.
Right, I'm going to stop you and want to open it up. But thank you both for, I think you're saying important things for all of us in terms of this election, and that we need the data, we need to be able to engage, and we need to be able to tell stories, and how we do that effectively and think critically at the same time. I think our students are being trained to do that, but we need to keep pushing on that. But I think it's important to have the training, but it's important to do more. And to be able to translate that. So I'm going to open it up. We have a few more minutes. I know Dr. Barbeau has an airplane to catch, but wanted to be here, so we're grateful for that. Thank you. But if you have a question, please stand, and we'll come around. I don't know if we have a microphone. Oh, okay. We'll help carry the mics back.
Hi,
Yes.
I know we don't
You can
have enough.
introduce-
Eric Goldman, I'm a supporter of the Columbia Mailman School. I'm just curious, thank you for a very interesting discussion. I'm just curious about, obviously we don't have enough time to talk about opioids and a lot of other crises, but how can public health be better at anticipating and getting ahead of some of these crises? So for instance, opioids. I mean, it was known how much was being pumped into the system. Where were we on that? Where are we in advance of some of these crises? And you know, the other thing is, you talk about, we're an employer in New York. We try to give the best benefits. We believe in income equality, health care equality, social equality. However, New York State, unlike other states, is against what we're doing, in the sense that all of our employees have the best health insurance. However, New York City doctors, many of whom are preventing those individuals from getting health care because they're now on a cash basis. Now it's become an epidemic in New York. On the other hand, Johns Hopkins Institution in Maryland has the support of the state, so they have access for everyone to see the best physicians. So, you know, and we're not commenting much about this inequality in New York City. We're talking about underprivileged, but people that have the privilege of having full insurance can't get doctors anymore very easily.
Thank you. I don't know which part of that, there's a lot of question there, but maybe the issue of getting out in front, because I do think that's something that's really important, and then also, you know.
Yeah, you know, I think this issue of getting out in front is something that we have been thinking a lot about, and part of what we are looking to do with this monitoring and surveillance system that I talked about we just built is, how do we bring in different sources of data that meet sort of our rigor standard in a way that we can have more real-time data points about what's happening, so that we don't get to a point where we have a flare. What I will say, however, is I think that this opioid crisis, part of what has shifted the narrative about how we engage individuals who are suffering from addiction has changed, because the social demographics of who is dying from this have changed. I think we can all agree that in the 70s and 80s, there was a crisis of people dying from heroin and crack. But we as a country chose to go the route of locking them up and labeling people, you know, crack this, crack that. But now that the social demographics have changed, we are thankfully embracing an approach of compassion. And so our job in public health is not to lose that frame now that the demographics are changing again. And so when we talk about being out in front, and to sort of tie in Brian's point that it's not just about data, it's how we in public health use that data to frame the narrative, and have that narrative, that frame of that narrative, be sort of the frame from which we all engage in improving the health of New Yorkers and of Americans.
So happy to talk after about this, but I'm going to argue that we're kind of just chasing crises, right? We didn't solve the obesity crisis. That's still happening. But then we're running over here to do the opioid crisis. Now we're going to run over here and do the vaping crisis. We're going to run over here and do something else in a second. And I think there's a commonality to a lot of our crises that kind of go back to those community foundations. And so I see a lot of these issues as downstream manifestations of upstream problems. And as long as we keep staying downstream, we're not going to solve them. So I mean, we're just going to wait until the next thing comes. It's like when I was a kid, I grew up in Boston. Go Red Sox. And when I'd go whale watching, right? If you really do a good job with it, you watch the water, right? And then you get to see a lot of good stuff. But what most people do is they're on the left side of the boat, whale pops up on the right side of the boat, they run over there. And then when they run back, and you're just chasing, you never really get to see anything. We don't focus on the water enough. Like, it's education. Of the 10 worst performing schools in this country, 93% of the kids in those schools are people of color, okay? Tomorrow morning, we're gonna wake up and send a whole bunch of kids in this country to really crappy schools. So I wanna talk about opioids, because that's a downstream manifestation of that issue. I don't wanna talk about obesity. It's a downstream manifestation of that issue. If we can't get that right, and we know it, that's the beauty of all this. See, we know how to solve these problems, we just lack political will, right? You know how to solve housing? Build more damn houses, right? There are policies that work. We've just chosen not to do it because we have no political will. That's what we need more than anything, is some political will to implement the solutions that we know work. And then maybe we can then not chase these kind of one-off issues, because again, all of our attention is going to obesity right now. Going to opioids, but the obesity crisis is still there. And then we got the vaping crisis. So it's like how many crises can we have simultaneously? Like, how many crises do we really have right now? And why can't we look at all of them? Like heart disease, diabetes, hypertension, all have common causes. But we keep the funding siloed, and by doing that, we water down our opportunity to actually make change. So I'm throwing out just a counterpoint of, it's not about opioids, it's about something else. And if we don't figure out what's further upstream, it won't really change.
I think we have a mic. Somebody, yeah.
This is for the commissioner, maybe if I can.
It's on. Go
I
ahead.
I think that the comment that communication is really the bridge between the public and the individual for public health and services that are being provided. However, I'm a little curious as to the individual. I think, at least in the immunization crisis, is focused more on the mother, and I'm wondering about the role of the physicians. And I think that your comment about that we used to live in our great society, I think our immunization coverage and our lack of communicable diseases was really just luck. And immunization coverage was never very high. I was director of immunization assessments for the Department of Health for 7 years. And a lot of the physicians didn't know the immunization schedule, or they didn't care, or they didn't communicate that to the patient. And so part of our role was to be able to say how to improve their coverage and what was the issue, and not the MMR before your first birthday, so don't schedule that appointment. So I'm wondering about where are all of the other issues of drill down on some of this and allowing the public to be able to realize that it's not just the mother who's refusing the care.
Thank you.
And with that, is there any discussion on, well, mumps might result in sterility in the boys? And so that being brought up, which it was to the yeshiva schools, increased the immunization coverage and
Why don't we
acceptance,
let the commissioner
and
answer
also
the question?
rubella.
Thank you.
So the good thing is that when we immunize people against measles, they get the mumps and rubella at the same time, as you know. So let me just sort of focus on a couple of things you said. I would disagree that our immunization rates are not good. School-age children in New York City, we have an immunization rate above 99% on an annual basis, which is great. And that's why we were able to contain this outbreak to very small pockets within the city because of herd immunity. I think your point, though, is in terms of addressing those smaller pockets in ways that doesn't put the onus just on the moms, right? Because moms tends to sort of take the brunt of all of these things. One of the things that we have found, I was on a panel a number of months ago with different individuals, one of whom was a nurse that was working closely with families and engaging them in the conversations about immunizations. And one of the things that became apparent was that when families go to the doctors, because of the way the health system has evolved, and me as a pediatrician, former pediatrician, right, you're lucky if you have 15 minutes to do a whole well child visit, and it doesn't give a lot of time to answer questions that parents may have. And so if parents don't have the opportunity to have their questions answered, they feel dismissed, they turn to the internet, and then we see what happens. And so really thinking about how do we not take for granted or not assume that the healthcare delivery system that has evolved to meet how it's been paid for continues to perpetuate these outcomes? And how do we build a system that's more responsive and more accommodating to individuals who may have more questions or fears, et cetera? And I think it was an important point to bring out that it's not about people who intentionally want to put their kids at risk, but it's the way in which systems conspire to make that easier for people not to immunize their children.
Do away with the religious exemption, do away with the medical exemption. If you don't have your immunization, you just can't go to school, period. Because us is more important than you. And that's a simple policy solution. Same thing with early pre-K. One thing that didn't come out, how much did measles cost you?
$6 million.
$6 million. $6 million. Now, you're fortunate that you have federal resources, but New York City is one of the very, very few places that have federal resources for public health.
Actually, the bulk of the money was city.
With city, right. So
Very
you're
very
picking
little
that up.
federal.
And interesting, some of the other cities in Big City Health Coalition, when we talk about opioids, who's footing the bill for the naloxone that we've pushed out? And that's a lot of the cities are footing these bills. We're not having that conversation, right? So, I mean, it's public health students, please remember that the money typically flows from the Fed to the state, and it's then the state's choice what to do with it. I spent a lot of time at DSHS in Austin, Texas, Department of State Health Services in Austin, Texas, and we would get the preparedness money, and you couldn't see Harris County and Houston from Austin. But we kept a lot of that money in the state, and we built capacity, when maybe we should have sent that back to where the actual disasters are most likely to happen, like Harris County, like Galveston. But that's a really important point, and if you don't have a really good understanding of federalism and how that kind of messes with public health, make sure to ask your whatever HPM or health policy person to do a lecture on how is federalism kind of screwing with public health, because that's why we can't say everybody has to have 3 epidemiologists, because there is no federal jurisdiction there, right? Public health is a state level requirement, and the state then controls, except in places like New York, the state controls the locals. The state makes those rules, right? So just be mindful of that and how that works. But from a policy standpoint, just whack the medical. If it's a medical exemption, it has to go to a panel, and no religious exemptions. We'll solve this problem, right? Because if I get pulled over for a DUI because I've been drinking, I don't debate the fact whether alcohol for me doesn't really cause me an inability to drive. They put me in jail, right? And that's because it's
Bad for us.
real.
Right. And I would add, I think it's $6 million in money, but it's resources, human resources. What other things you had to mobilize your staff to respond and do and other kinds of
Do you
things.
remember what it cost, Jeff?
I think we
He
had one
didn't
more,
say.
if we have,
Yeah.
do we have time for
Yes.
one more question with
Yeah,
you?
yeah.
I think we had someone in the back who was raising their hand for a while.
Okay.
Oh, okay, you have the mic then, there you go, okay, please.
My name is Brian Konate. I'm a second-year EPI student in the MPH program, and I know that as students at Mailman, we really are rooted in data and community-based needs. But kind of going back to your Kyrie Johnson and the Flat Earth example, we're really moving to this kind of influencer society where public figures do have a lot of weight in how we think about a lot of issues, including health. And I was just wondering, when we've been working years and years on building up evidence that can be called into question just because of 140 characters or an Instagram live stream, how exactly do we combat that if we're working in government, and what skills can we gain as students to really prepare us for that?
Oh, that's a great question.
We have great students.
Yes, yes. So one of the things that distinguishes the New York City Health Department from other health departments, and Brian sort of alluded to it, is that we have more resources than any other department in the country. And so we understand that with having those resources, we have an obligation to put together resources and practices that then can be exported. One of the things that we do really well is we've got a very robust communications department, and we're on these various platforms, social media platforms, but we also are focused on pushing the envelope in terms of the campaigns that we put out, right? And the way in which that then changes the conversation in public health about a particular issue. So the latest example is I was, and this is where I might get a little political, I was reading an article in the New York Times about a recent Lizzo tweet where, she put in capital letters, I am, and then the emoji peach, and then, MENT. And so the conversation was about how that emoji has changed from sort of meaning one thing to now being used as another, right? And so we have a pretty racy campaign about, getting a slice on the side and the peaches and the eggplants, and I'm like, I'm getting schooled by my folks, but it's very relevant to what's happening in the world. And in terms of then looking at how we have folks within our department who, as standalones, are influencers in their communities. So for example, Dr. Dimitri Daskalakis, who is our deputy for disease control, he's amazing, and so he has a huge following. And what we do is we look at the uptake of our social media, and we do the analytics, and we find that when I tweet from the commissioner account, it gets good traction, but nowhere near where Dimitri might get it. And so being strategic about how we use influencers within public health that are also influencers within other parts of, communities that we want to influence. And then the other thing I'll say around that is yesterday we launched a campaign, social media campaign on vaping, targeted towards teens. And we had a conversation about how do we use that same approach of targeting influencers in these domains to get our message out. And this is where we kind of came up against, we don't know that we will ever be able to find an adolescent who wants to be associated with the health department. It might kind of, put a ding on their influencer status or ranking, whatever that is. But I think, your question is really important because we don't shy away from the foundation of the data and the accuracy of the information, but we are mindful of the fact that we may not always be the most credible messenger or the most effective messenger. That certainly played out in the measles, where we used a lot of leaders within the ultra-Orthodox community to carry that message for us, and that was great. I didn't see that as a failing on our part, but as a recognition that it doesn't always have to be about us. And so I just lost my train of thought, but that was a great question. Thank you.
The Public Good Project here in New York City is doing some of this work where they're finding influencers who can then put out messages. They actually did a study to see if they used social media influencers, if they could get people to get flu shots, right? Because they're not really listening to us. We're government. We're in big, ugly brick buildings. They're listening to the Soccer Mom 17. They're listening to DJ something something. And when DJ something something says, hey, before you come see me tonight, get a flu shot. People get a flu shot. So we have to figure out how to do that, and we need to get out of our kind of government mentality. Oxides is right. I mean, New York is super progressive. I would say look at Kansas City, Missouri Health Department, super progressive in what they're talking about. And, they have to know you. Like if the first time you're going into a community is when there's a crisis, you've already lost, right? So how do we make some, I used to do, because I'm an epi, I came up as an epi. And so the community would say, Brian, can you come and show us the data, right? And you could show the data and I never do confidence intervals, I never do p-values. All the data broke down to 3 colors, red, yellow, and green. And I said, find where you live, now watch. Boom, 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 went through like 80 slides. I was like, were you ever not red? And I said, that's your problem. Now let's talk about it, right? And it was able to galvanize a community around like, why are we always red, right? And the data are there, but we have to figure out how we're presenting it and allowing people to use it. And I don't know that like classic academic epi is teaching us how to do kind of like rock and roll epi, right? Which we need to do a lot more of, because the stuff we have is cool. We just need to figure out how to make it interesting, right, and accessible.
Right. And we need to, I think a common theme I keep hearing from both of you is we can have the data and the answers within our institutions, but we have to partner and engage outside. And we have to find influencers and community members who we can empower with the information and the data, but who may have more influence that goes beyond what we can do.
But let's be clear about where we are, okay? We're trying to get people to eat healthy, right? What is the marketing budget of McDonald's, Coke, Burger King, and Pepsi combined?
A lot.
Right? Yeah, more money than we would ever have in public health. So now that if we can level set there, okay, so we're never going to have their cash. What are we going to have, and how do we develop those assets? But I think we need to do a very honest asset mapping within public health, and our community relationships, our communications could be an asset for us, and we're just not. We're not using it.
I'm going to be respectful of your time. I know you have to go. We have breakfast outside for those of you, and I know Brian will be here for a little bit longer to answer questions. And so thank you both for a really exciting and engaging conversation. Appreciate it. Thank you.